had surface replacement?
Yeah, ladies and gentlemen, good morning. It's something like an overview. We have now many other lectures about the resurfacement, and the resurfacement is very popular, especially in the UK, rather than the rest of Europe or in the world. So in Germany we have about 20,000 arthroplasties a year, is much more or less comparing to hips or knees. And there's an increasing number of both on the reverse side, the elderly patients, and we have the younger one. And for them, the resurfacement, or in the last year, the stemless arthroplasties are becoming more and more. So for the selection of design, what is important when you have a lady like that here of 18 years after atraumatic instability, after multiple procedures, especially arthroscopic procedures with ankle problems, hardware problems, push lock problems, and anything like this. We see more and more those patients. You have to consider what is the right design, because more in terms of indication, less in terms of indication rather than the age and the expected survival rate of an implant. And you see this is now 10 years after the implantation of the resurfacement, and now it was necessary to do a conversion to anatomical one, and on the other side it's still in place. And it's just 10 years, but now this lady is 38, 39 years, and what is it for the rest of her life? So yeah, there is an obligation to consider about the age, the expected long-term results, further options, is there chance for revision, and so on. And the evidence in literature is, I think it's not very clear. So at this time in 1999, when Steve Copeland, he was not the first who developed the resurfacement. It was, I think, the most important, because he has now brought this concept to in public, and more and more surgeons decided to follow him. And at this time, the potential advantage was that there was minimal bone resection, short operative time, low prevalence of humeral periprosthetic fractures. It was easy. At this time, we were convinced to do a conversion to any anatomical prosthesis, to have no osteotomy. And one idea was, and I think this was not proven at this time, that it's a better reconstruction of anatomy by the resurfacement. Stephen then published the results in different indications, and he has shown excellent results. And I must say that most of the authors after him were not able to reproduce these excellent results. And the revision rate was very low. For osteoarthritis, this last report, less than 1%, whatever this means. And on the ICSS on Costa de Salpa in Brazil, he mentioned that he has only seen in his whole material, huge material of about 200 arthroplasties, he has seen only one case of glenoid erosion, and the 10 years calculated survival rate of 96%, which is incredibly good. From these excellent results, we have been more reluctant. When you look in our own material, this about 2006, 2010, nearly 1,000 arthroplasties, but only 10% of resurfacings. And this means that we did not believe that everything is true around that. And now we have follow-up time of 10 years, and we reviewed our first 100 caps with 3 different designs. First we used the Copeland, afterwards the Epoca, and then the Tourney resurfacing. And this was used mostly in young patients, less than 50 years old, and very rarely with glenoid resurfacing. A good indication are young people when the glenoid surface is quite well preserved, and then you have to put in a resurfacing with, I feel, good predictable results in young, active patients with good bone quality. For the avascular humeral head necrosis, you have to do the resurfacing before the glenoid surface is damaged and destroyed. Then you may have very good and excellent results as well. For the rheumatoids, you have to consider that you have a poor bone quality. The rotator cuff is mostly thin, atrophic, sometimes torn. You have erosions, and the bone stock can be very poor, and you need, for the juvenile rheumatoid arthritis, sometimes very small caps. In Germany, there's a large series with a long-term follow-up published. Surprisingly, they found no difference in patients with torn or intact rotator cuff. This, for me, is hard to believe, and I feel that there was a failure done in this trans measurement in this paper. For patients of high-level physical activity, like in this bodybuilder, this is a good indication. Even when these people, they are eager to do their activity further for weightlifting and bodybuilding. You see, this guy was 2 years after surgery. It was the championship in Germany, and was able to use his arms without any problems. Even with this problem of, you see here, we compare the preoperative and the postoperative with glenoid wear. What does it mean, glenoid wear? Is that the glenoid erosion is the main problem? And we have seen over the 10 years more patients than we expected with this problem, where we have seen this progressive glenoid erosion, which is painful. Not always is painful. It can be painful, and is a matter of concern. A co-worker of mine, Ms. Werner, has published this already. And here's an example of a gentleman 1 year after surgery. It was a centered osteoarthritis. It was very painful, increasing pain and pseudoparesis. And after conversion to a total arthroplasty, he is doing very well. I think you have to keep this in mind that sometimes the resurfacement is not a good idea, especially when you try to do it with different designs in the shoulders. We started once a study to do a resurfacement in one shoulder and the total shoulder on the other one, but after 2 years we have to stop this study because it was ethically not possible to perform and to come to the end, because all of the patients who have had a resurfacement on one side wanted to have a total shoulder on the other side, were seeking for a revision. So for that reason it was necessary to stop this study. This problem of glenoid erosion is well known, and there are numbers from the Mayo Clinic who show you very clearly that the crossover rate is about 20%, with increase of glenoid erosion of about more than 10 years when you look on the X-ray. And our own material with Werner has now evaluated that very in detail, and she found that there's a glenoid wear of about 2.2 millimeters a year, and the progression over a minimum of 3 to 4 years, and it starts very early. So we have seen, even when the constant score is acceptable, we have seen nearly 10% of revisions to total shoulder because of glenoid erosion, not of loosening. We have never done a revision of a cup because of loosening. It was in all these cases it was stiffness, pain, and mostly due to glenoid erosion. And when you do a failure analysis in all these cases, you can say, okay, this was not performed in a proper way. You have a varus position, you have this oversized, you have glenoid erosion. What is really the reason for an unfavorable result?
Jetzt mal hoch, Hinterkopf,
only if you have a hyperlexation like this one. This is with the MDI.
Ja, jetzt mal umdrehen, von der Seite, dass man sieht, dass Sie nach hinten können.
In order to stabilize the joint, he was doing very well. But this is the exception of the rule in those patients where you are able to do this and you can do that. We analyzed our patients and we have seen that on average, even when we were aware of this problem and tried not to overstuff, we have seen more than 2 millimeters lateral increase of lateral offset in all our caps I personally have done over the years. So this may be due to the technique of Stephen Copeland, who just ream away a little bit the cartilage and then put the cup on the bone. And he liked that. We are now convinced that this, we should not further follow him in this way. What about resurfacement and biological glenoid resurfacing? There are many ways to do it, and there are some reports, very few papers. In our hands, I can tell you that all of them, we have never seen an excellent result. After this kind of resurfacing, we have seen many failures. What to do? Put in both a glenoid resurfacement, glenoid component, and humeral head. It is possible. It's possible especially when you have lax cases, but in osteoarthritis cases. And there is one paper given from a German group. They have observed a considerable high number of neurological complications, nerve palsies, plexus palsy, probably due to the fact that it's a very tight situation. And when you try to put in a glenoid, you have to push back the head and put in a lot of hormones, and this may be the fact that you produce these problems. So the key issue is the exposure, and therefore I would not really recommend you to do in all these cases a total shoulder together with a resurfacement. What is to do in glenoid dysplasia? Here you see this is a nice example, 40-year-old manual worker, and we decided to put in glenoid resurfacement. You have not so many good options. You can do a ream and run procedure. We have seen not really good results with this Madsen procedure. Put in a hemi, total shoulder bone graft, which may fail, glenoid osteotomy, which was fail, and so on. But over the years, we observed that sometimes when you do a remodeling of the glenoids, put in a resurfacing, like in this case of a 43-year-old manual worker of a carpenter, in a type C glenoid dysplasia, that after 6, 7, 8, 9 years, when you have to do the conversion, sometimes there is more bone stock for fixation of the glenoid because of the remodeling of the glenoid. We have observed it. This is not a predictable thing, but sometimes it happens, and then you're very happy that you have now seen over 8, 9 years that the glenoid tilt is improving. For the post-traumatic cases, when you have a situation like that and try to put in a cup, mostly you are not very happy. First, you are not happy when you look on the X-ray, and the second one when you look on the patient, because most of them are stiff and they're not doing very well, and deformities are very hard to correct. And there's a paper given from a German group who have shown that, especially in the valgus deformity case, it may yield acceptable results, but in the varus case, the results are mostly poor. So I feel that for those cases with varus deformity and loss of bone, and stemless implant is mostly better and provides better and more reliable results. There is the tendency now to use the cup for kyphotropathy instead of the reverse. It may work, but it works mostly only in patients when they have a good elevation of more than 18 or 90 degrees. This seems to be the limit. And they have still an teres minor and the subscapularis. And when you are able to preserve the subscapularis, then you may have a good success and clinical success with the resurfacement. But in case that you have a secondary rupture of the subscapularis, the patient is even worse as before after implantation of such a cup. And so there is some warning about that. If you'd like to do it, always try to preserve the subscapularis and be aware that you have enough remnants of the rotator cuff. I must confess, in our hands, when you look now on our data bank of more than 1,000 arthroplasties, that the resurfacement was the worst in terms of revision rate. Even worse as the reverse arthroplasty, mainly because of the problem of glenoid erosion. And when you do the revision, you see mostly this kind of empty humerus. That means that inside the bone you have only fat, and all the bone disappeared. So I feel from that point of view to say that you have a bone proceeding procedure is not absolutely right. You have to consider that in the long run, you may have problems that the humerus is like an eggshell. So coming now to the conclusion, we are not really disappointed with the results of resurfacement, but now we know the limits, and I feel it is an option. But it may happen that in future the people will use, instead of the resurfacement of the head, the so-called stemless implants, in case that they provide similar or better results. Thank you very much indeed.
Are you going to take questions? Do you have any questions to Professor Gohlke?